We'll get started, even though I'm sure we'll have some people coming from the other room. So today I'm the speaker. I'm introducing myself, and I'm going to speak about mental health implications of blindness and vision loss. But before I do that, I will say the usual things. First, there'll be an evaluation at the end, and make sure you fill that out. A QR code should come up, and there'll be a link that should be sent out tomorrow by email, and also probably on a slide at the very end. Also, we hope people have questions or comments, but make sure to use the Q&A box at the bottom of your screen to submit those. Don't use the chat, which is reserved for the interpreters and the panel. And if you're watching on Zoom, your mics and cameras are off. That is on purpose. And that's it. All right, so I'm very excited about this topic. And in fact, I asked Sephora not to introduce me so I could have more time to talk about it. Plus, I figured everyone knows who I am already. I'm the Associate Chair for Research, Professor of Psychiatry here, etc. All right, so on to the topic. What I'll be covering today is some basic facts and findings about blindness and vision loss, and then I'll discuss some of the common forms of vision loss, give some examples, and then move on to unmet mental health needs in this population. And then to make the problem worse, I'll discuss how there's a lack of available mental health services designed for people who are blind or with severe visual impairment. And then I'll provide some recommendations, some of my own and others that have been put out there in the field and white papers and things like this. I'll discuss some resources that are available, and then conclude. All right, so first of all, I want to say this is a big problem nationwide and worldwide. More than 3.4 million Americans are now aged 40 years and older, are judged to have to be legally blind, meaning visual acuity of 2200, meaning that what someone else can see from 200 feet away, you can only see if you're 20 feet away. Or having a visual field that's restricted, so 20 degrees or less, about this much. So this is a big problem nationally. There's estimated to be over 500 million people worldwide who have significant visual impairment, and about 80 million Americans have potentially blinding eye diseases. And of course, some of these are age-related, like age-related macular degeneration. So as we all get older, this number will probably go up. The major causes of this vision loss generally are cataracts, age-related macular degeneration, diabetic retinopathy, and glaucoma. But of course, there are many ways to lose vision. You can, I know someone who lost in a car accident. They had to get both eyes removed after that. Someone woke up from an operation that used anesthesia. He was blind after that. So eye injuries, there are many ways it can happen. And I will say, from an economic point of view, it's a big problem as well, because a recent estimate was in the United States alone, the cost of vision loss is over $134 billion. With most of that being direct costs, but some of that due to lost productivity as well. Okay, so I want to give some examples for people who aren't familiar with these conditions. One is macular degeneration, usually referred to as age-related macular degeneration. There are two types of this condition. There's the wet or neovascular type involving growth of new but unstable blood vessels, which can leak, and this interferes with vision, or the so-called dry AMD that involves essentially atrophy of the part of the retina that nourishes the photoreceptors. So this leads to vision loss. Early in the course of macular degeneration, what people typically notice is in the center of their visual field, which of course is what your macula is responsible for, the sharpest vision in the center. Things start to seem a little darker, a little blurrier, and sometimes distorted, as you can see in this image and on the Amsler grid. But with advanced macular degeneration, you unfortunately get situations like this where there's more blurring, and then there's literally gray spots or black spots or areas that get larger and larger over time where you really cannot make out what's happening. Something that's similar in effects to macular degeneration, but that can start at a much younger age, even in adolescence, is Stargardt's disease. Essentially, it's another type of macular degeneration. And as you can see here from this example, again, what people are losing is central vision, and then that amount of central vision, or that scotoma, or the area where they cannot see things well, gets larger and larger over time, eventually into the periphery, and can lead to near total blindness. Now, another condition that's not physiologically, but in some ways the opposite of macular degeneration, is retinitis pigmentosa, which is essentially a disease that involves probably some of over 100 genes that have now been identified. And this condition involves vision loss in the periphery that over time increases so that ultimately people can lose central vision. And so here's an example on the right of what the visual world may look like for somebody with this condition. So again, it's progressive over time. And many people with diabetes go on to have diabetic retinopathy, and this is associated with excessive or new blood vessel growth in the retina. These blood vessels can break, they often do. Blood can leak into the retina. Parts of the retina or blood vessels can break apart, and interfere with vision. So this kind of patchy vision loss, which can get worse over time, is common in people with diabetic retinopathy. And glaucoma, I wanted to mention, is a condition that's now considered a neurodegenerative condition, and there's some interesting links with Alzheimer's disease with it. But it's a condition that traditionally has been thought of as a disorder of peripheral vision that involves the optic nerve, which leaves the retina at, as you can see here, the optic disc. It's the axons of the retinal ganglion cells form the optic nerve and leave the eye. It's a synapse in the brain. And so the retinal ganglion cells are affected by glaucoma, and then the optic nerve that leaves the retina. And typically people with glaucoma report not only trouble with peripheral vision or loss of peripheral vision, but also that they need more light to see things that they used to see, and things are blurrier as well. And again, these are all progressive. So, and these are just some of those are the main causes other than cataracts. But of course, there are many ways to lose vision, as I mentioned. Now, for people who have these conditions, there are a number of services that are available. And we have great services here at the Flower Eye Institute. Certainly, we have a great ophthalmology department, and there are many optometrists as well. These are people who typically diagnose and sometimes treat, especially ophthalmologists, these conditions. And then many people, though, after that, need some type of additional services. So they may need, for example, to get special glasses that have high magnification lenses, or have some magnifier that goes over their computer screen, just as two examples. And this is the domain of low vision therapy. Many people need more than that, though. They may need to learn ways to live in their home or to work in their work environment, given that they've now lost a lot of vision. And this is a domain of vision rehabilitation therapy. And then there's another group of specialists called orientation and mobility specialists, O&M, and they're the people who teach people how to use the white cane, for example, which is a skill that has to be developed, or help people with a guide dog. So this allows people to, especially with severe vision loss, to get around on public transportation or walking around town or wherever they want to go. And of course, vocational services are often needed as well. Now, vision impairment obviously means there's impaired vision, but there's also impairment in many other areas of life very often. For example, your social status can be affected. People may not be able to do the same job they had. They may have less money now. Relationships may change. People's sense of self-confidence goes down. Many things become harder and have to be relearned. And so these are some of the issues that are not traditionally addressed by vision rehabilitation. So I know in New Jersey, where I was at Rutgers for many years before this, the Commission for the Blind and Visually Impaired in New Jersey had a great set of services for vision rehabilitation and vocational rehabilitation. But for people who were depressed, secondary to the vision loss, they had no idea what to do. There were no services related to that, and they didn't know who to refer them to. And in fact, there weren't any people to refer them to. So very simplistically, you could think of adjusting to any major change as involving a cognitive component, knowing what's going on, then a behavioral component of knowing what you can do about it, and finally, the feeling component. And I'm here to say, I guess, that that component is often not addressed in people who have lost vision, even though it's a significant component that should be addressed. And that's really what I'm focused on here today. So to quote something from a really excellent book called, well, I can't remember the name right now, but a really excellent book from 2000, I think it was called Self-Esteem and Adjusting with Blindness. Adjusting with blindness is less than satisfactory unless the individual reaches the potential of self-acceptance and self-esteem as a person, first of all, and then as a person who happens to be blind, right? So this is the ultimate goal. Of course, it's important to get people to use assistive devices, screen readers, magnifying lenses, et cetera. But ultimately, if the person's going to have any kind of quality of life, they have to regain the sense of self and a sense of relevance in the world. And back in 2020, a graduate student and I wrote a review at that time of what the data said about rates of depression, anxiety, for example, in people with vision loss, sudden vision loss or gradual vision loss, et cetera, and what the treatment options were. And actually, just to summarize this fairly long paper, the data are very consistent that people who have lost vision or are losing vision have significant rates of depression and anxiety, and there are very few services that have been developed for this population, and most of them aren't effective in reducing depression and anxiety. So that's kind of the gist of it. But there are exceptions which maybe point the way to where things can go. So in terms of depression, which is probably the biggest problem, when people first access vision rehab services, a number of studies, including these are some of the better ones, I think, indicate that the prevalence of depression measured different ways, whether it's diagnosable depression or high score on the PHQ-9 or whatever, is about 30%. And that's found consistently over a number of studies. This is a study that came out just a few years ago that was based in data collected by Sylvia Sorensen, who's at the Warner School, and Rajiv Ramchandran from ophthalmology. And this was from over 200 people living in senior living facilities, about 30% of whom screened as potentially having depression based on the PHQ-2. And the interesting finding from this study was that the objective tests, like retinal imaging, whatever, those scores weren't related to level of depression. But what was related was a combination of visual functional impairment. So they were having trouble reading, or the acuity on the eye chart was poor. That and having very little social support. And that social support theme comes up in a number of studies. So this is true today, and it was true many years ago. For example, in 1970, you can see this is not new. This was a study of 66 people who, when they first were diagnosed as having an eye problem that essentially meant they were blind, and then 3 months or more afterwards. And the points I want to make here is the first line shows that at least initially, over 80% of people had significant depressive affect in this population. But at the same time, as you can see here, very few of the people were in any kind of psychiatric treatment. Now you might say, well, that's 1970, with all the stigma, now it would be higher. But actually data from now show only slightly increased rates of this, as I'll mention in a study later, but maybe around 10 or 12% of people who are clearly depressed when they go to eye clinics. This was a study of over 1,000 people from the UK. 43% of people seeking help for sight loss were rated as having significant depression, and which is about the same as what you'd see in cancer patients, where we all kind of recognize that depression is a problem that should be treated. And in fact, we have psychologists over in the cancer center working with people over there. 3/4 of the people who were screened positive for depression were not receiving any form of treatment at all. I think 12% were receiving medication in this sample. So it's still true today as it was true in 1970. And the authors were only aware of 2 low vision services that screen people for mental health issues in the whole country. When I was in New Jersey, there were none there at the time. So people aren't getting the help they need. And that's in the UK. Other international findings are again similar. 3 studies that were done during the COVID pandemic, during the height of that, showed about a 40 to 60% rate of depression in people with vision loss. And studies from before COVID also show, again, that rates of around 30% in a number of studies. So what does the depression look like or seem like? I just want to make a few points about that. Of course, people have depressed affect. There's often hopelessness, etc. But anxiety is a very frequent problem in this population that often goes with depression, as it often does, but it's certainly true in this population. Low self-esteem, again, it's as if everything that was taken for granted about what you do every day, now you have to learn a new way to do it. That is it is overwhelming for many people. Many people who get depressed after vision loss have an external locus of control. They don't see that they can do something about it to get themselves back to being a functional person who can have a happy life. People who don't have that external locus of control are much less likely to be depressed. And of course, many people assume they're not going to succeed, whether it's walking around with a white cane or learning to read Braille or just, going to a social event where you can't see people very well. These are things people can learn to do. Many people learn to do them, and they do them well. But initially, most people don't assume they can do them well. And again, it does seem like an overwhelming task. So they assume they're not going to do well. They don't even try. And one of the issues, of course, is getting people to go to vision rehab services. Depression gets in the way with that, and so that's a major issue. One of the best predictors of depression in people who lose vision is their prior beliefs about vision loss. Many studies show that if you ask people, what's the worst thing that could happen to you? Losing your vision is at the top of that list, even higher than cancer. And many people have a lot of stigmatized views about blind people. So then if you become blind and you apply that to yourself, that's a big problem. Many people also don't fully acknowledge their own sight loss, like many other problems that people have. And I do want to say that the problem is not limited to older people. About 75% of the people, at least in the United States, who have significant vision loss are over 40. I don't know if that qualifies as old, but there are plenty of people under 40, so 25%, who have these problems as well. So this one study showed that of adults over 19 years of age with loss of visual function, the rate of depression was still pretty high. It was 11.3, which is over double the rate of people over 19 who did not have vision loss. That was the study used the PHQ-9. And those results held even when controlling for all the usual demographic factors. I put the whole list here, even though it's like maybe too much information. So again, it's not only older people. Now, one question that's really important is, well, does this last? Because of course people are going to have a reaction emotionally if they find out they have an eye disease, and they go to the doctor because they've noticed they're losing their vision. But the data suggests that without intervention, often it doesn't just get better on its own. And it doesn't even get better necessarily even if you learn how to use adaptive technology. This study is from 1992 of 104 people. And you can see in the middle and right column, the number of those people out of the 104 who improved 2 years later on these various psychological domains or declined. So the first thing you can tell from this is most people stayed the same, right? Because these numbers are just, they're not the majority of 104 people. On the other hand, many more people declined than improved. So if you already feel like you have nothing to get up for, well, nobody reported that improved over 2 years. 17 people reported it declined. So just you can take a look at this and see that, and I'm showing this because this is maybe the only longitudinal study of this issue, that again, there's a need, not just initially, but over time. You can't just say, oh, you'll feel better soon once you learn how to use this or learn how to do that. These are data from a study, I mentioned a study before, of over 1,000 people from the UK. And this study was the one that showed that 3/4 of this group were not getting any psychiatric treatment at all among the people who screened high for depression. So this is cross-sectional, but still it shows that starting from less than 6 months from the sight loss to 10 years or even greater than 10 years, the rates of depression were about the same. The average rate was 43% of the population of people with vision loss, and that's the line. And the year to year, it's around 43%. Okay, so again, something should be done. It just does not go away on its own. Now, I want to spend a few minutes talking about what makes the situation even worse. You could say, well, it's already pretty bad, right? You're losing your vision, you can't see, you have to relearn everything. People are treating you differently, not treating you as someone with independence, et cetera. But sometimes the diseases that people have or the conditions are associated with symptoms that are also stressful, like Charles Bonnet syndrome, where people who have retinal damage, for example, often will start to hallucinate. It's as if, like when you go in a sensory deprivation tank, because of the retinal damage, there's less visual input to your brain, so your brain kind of maintains homeostasis and generates visual percepts. For many people, this is distressing. For many people, it isn't, but still, for many people, it is. And many people who are starting to have these hallucinations, often they're of little people, or they're complex, they're not just shapes or whatever. They think they're losing their mind, or they think they're becoming demented, which, for the average person who doesn't know that much about psychiatry, they just know something's wrong. And that's why sometimes people go into nursing facilities or assisted living facilities and give talks, psychoeducational talks on this kind of problem, because that's very helpful to people. And there are a number of other behavioral techniques that people can use to make the hallucinations go away if they start to arise. And I also wanted to mention for neurovascular, the wet AMD or macular degeneration, one of the treatments that can be effective for that is to get injections into your eye of something that slows down or prevents new abnormal blood vessel growth. And as you could imagine, that's not enjoyable to do. Nobody looks forward to that. This is a study of 130 people with that condition that they surveyed. People need support to go for these appointments. The week before the appointment, a third were reported themselves to be stressed, and 15% had sleep disturbance. And most of the people thought the treatment was uncomfortable, which, how could it not be? Again, this is not your run-of-the-mill treatment that you go to the doctor for. And then to pile on about what makes things even harder, it's pretty rare for ophthalmologists or ophthalmic nurses to ask about mental health issues. Screening for mental health problems is not common in eye clinics. Asking about this isn't common. One reason is there's no time to do it, right? You know how it is. Doctors don't have the time to get into these extended discussions with patients often, and that's an issue. So, but from the patient point of view, that's a potential way to get referred to mental health care. That's not happening. And of course, then the person feels like they're walking away from the appointment without having even discussed something that might be one of the most important things on their mind. Many people do feel a loss of power and competence. And again, if that's something, it's hard to describe, but it's it's really kind of a disabling feeling to have that. Many people report that they don't even know who they are anymore, right? So they have to relearn, reestablish their sense of identity. And I mentioned before that, especially for people who had stigmatizing attitudes or negative attitudes about blindness, it's even worse. Many things are more difficult. So it's not like you can ignore this for a month, right? Because you're constantly, whether you have to cook something or be told that you can't cook anymore or whatever, there's many situations. This affects, daily living, including ADLs. There are many situations that make people angry. If you're with a bunch of people and they say, oh, look at that. Okay, well, if you can't see that, then that happens. That's not good. Balance can be an issue. There's a higher rate of falls with people who have lost vision. Of course, stigma, which can be internalized. And people feel, a few years ago, we were talking about microaggressions. There's a lot of microaggressions and macroaggressions around people with blindness, and that's associated with worse mental health. It's harder to be spontaneous in social interactions if you can't see people, or if you're at a dinner and imagine eating when you can't see. There was a restaurant in New York City that used to have these dinners, or it was this Vision Loss Alliance of New Jersey would sponsor these dinners where you would go and eat in the dark with a blindfold just to see what it was like. It's not, very few people are good at it initially. Concerns about attractiveness and sexuality. You can't even, it's harder to keep yourself looking the way you want to look. And then, of course, you wonder if people are going to still think you're attractive if you have a cane, for example. And there's some good literature about the need to be a good communicator and assertive, that it becomes more important than ever to be an assertive communicator about what you need in the world and with your family and people you live with. Okay, I mentioned social support before. I wanted to mention this study. This was done during COVID. Again, greater perceived social support was significantly associated with lower levels of depression, but negative social support, meaning overprotection, which is a big problem when you work with family members of people who've lost vision, even when the people were very, and still are, high-functioning people. But the sense of overprotection kind of becomes very prominent, and that's related to more depression and more functional disability and reduced sense of mastery over everyday tasks. So I'm trying to paint a sense of how complicated this can be. You have not only the vision loss that you have to cope with, but then often you're coping, you need social support, but it's got to be the right kind, as well as access to a lot of services. Now, consistent with our focus on wellness here, people have said, yes, we have to treat depression, trauma, anxiety, et cetera, but we also have to treat well-being, right? Wellness should be a goal, not just reducing the depression. And I just want to emphasize that's important in this field as well. So related to that, you can think of blindness or losing vision as something that has to be adjusted to, that people go through stages of adjustment to. So just for example, back in the 1950s, there was some discussion of this already, from this initial denial or shock, depersonalization, to depression, and then a sense of personal recovery. That's quite a common trajectory. But I wanted to focus on this book I mentioned before from 2004, which I highly recommend to anyone interested in this work. One of the most useful books I think I've ever read in the field. They talked about also an initial reaction that started with whatever the trauma is, whether it's a disease or an eye injury, and then an initial stage of shock or denial, again, which is very common, and then a sense of starting to withdraw and mourning. And I want to put this quote here, which is, at first, you may disregard what's happening or believe it can't be permanent, but after a while, you begin to wonder how you can go on being yourself. So it's as if the task of what you're losing and what you're going to have to do to regain, your sense of self initially seems very large and overwhelming, which ultimately leads in many people, about a third of people, to a significant depression. But what happens with many people is that they come out of these stages into what you can think of as like a rebuilding or a recovery stage, where people essentially kind of decide that this way they've been is not how they want to stay, and that they are going to now take action and do things to help themselves. So there's a reassessment and reaffirmation that they're a worthwhile person. They have a lot to offer other people in the world. There are many ways to learn coping skills with these things, this type of these visual impairments. Many people who can help with this, many effective methods. And ultimately, you want self-acceptance and self-esteem as the ultimate goal. And it's important when you're working with people, of course, to try to understand where they are in this process. Of course, it's not totally linear. It never is. But it still helps to use this as a framework to think about where somebody is and what kind of issues they're dealing with and what kind of interventions they may need. Now, so I think we've established that depression is a problem in people with vision loss, anxiety as well, and it can be made worse by the environment, lack of support, etc. But you would think if only people would be interested in going to mental health services, but that assumes that these services exist, okay? So they mostly don't. This, of course, is over 30 years old, but they still don't today. I wanted to mention this because there's so many people in our department of psychiatry interested in suicide. This is a quote from a 2014 paper. The literature is silent regarding proper approaches to diagnosing and managing suicidality among patients with visual impairment, especially age-related macular degeneration. Now, partly, those are older people who have, maybe lost spouses, they have other age-related issues affecting their mental health, but still, about over 30% of people with age-related macular degeneration have been found to meet the criteria for a depressive disorder in various studies. So this paper, which just came out a few months ago, it was a systematic review and meta-analysis. So this gives you an idea. There's already a decent literature out there on this, and it was in, JAMA Network. So this was based on 31 studies, and you could see that the odds ratio for suicidal behavior in people with visual impairment is well over 2 times the general population rate, 2.49. For behavior, it's over twice for ideation, and the risk is highest in people in adolescence, where you could say there's more impulsivity and maybe fewer coping skills as well. So this is a problem, and not only depression, but suicide as well. Now, many people who have these problems of vision impairment and depression say they want help when people have been surveyed. It's not like they don't know they need help. And so these are some quotes. For example, one person said, "I would have appreciated psychological help to discuss emotional problems such as anger and grief. Right now, I'd still like and appreciate this help." So this is fairly common. And partly because many people, they want a professional because it's hard for them to talk about with their spouse or some of the issues that they're having and how they feel about themselves. Okay, so what are some of the barriers? I wanted to mention that There's a national organization called Prevent Blindness, and the head of the scientific board of that is Rajiv Ramchandran, who's a retinal surgeon here in ophthalmology. And I'm on that scientific board. And about 2 years ago, we formed a committee of people who were living with vision loss, psychologists and psychiatrists who had some experience working with the population, and social workers and others, and developed essentially a set of recommendations for both ophthalmology and psychiatry. And these were some of the issues that were raised. One is there is a limited awareness of mental health needs among eye care providers. Again, they don't have a lot of training in psychiatry. They don't have time to ask about these things. Interestingly, just as an anecdote, once when I was visiting the Lighthouse in New York City, I was meeting with a low vision therapist. So she's the person who helps people with magnification lenses and screen readers and assistive devices. And she was saying that about half of the time that she spends talking to patients, she feels like she's being a therapist. The other half, she's actually showing them devices and teaching them how to use it. So people do want to talk about this, but obviously it's not happening in the appointments with the ophthalmologist. So limited time to address these needs, of course, a shortage of trained providers. This is in psychiatry now, with knowledge and experience regarding vision loss and coping with it. I was co-leading a group for a while in New Jersey, and a number of people there said, you know, they were referred to a grief counselor, which I guess was the closest thing that someone could think of to, you know, because they were grieving the loss of vision. But it really wasn't helpful because the person didn't have any specific knowledge about what it was like to live with vision loss. You know, it's different if someone dies, you know, in your life. Again, the stigma, including from potential providers, and even sometimes from other blind people. There was a great article a few years ago in the Braille Monitor about someone at the National Federation of the Blind Convention. And the NFB is a good organization, but they have a real strong philosophy, essentially that blind people can do anything anyone else can do as long as they have access. They don't need pity, they don't need help, et cetera, et cetera, et cetera. And that this one woman was saying how what she noticed is everybody would sit around in these groups at these NFB meetings and talk about how great they were doing, and then they would go out for lunch or dinner afterwards and talk about, you know, all the problems with depression and everything else. And why couldn't they talk about that at the meeting? It was almost like you don't discuss this there. So it's complicated. And some eye care providers don't like the idea of referring people to psychiatric help. It's like they feel like it's a form of giving up. Okay, now, if people had these problems of vision loss and mood disorders, and there were services that were available, I guess that would be good. But of course, the services aren't available. And what makes it worse is that the services that generally have been tried aren't really even effective. There are some studies that show effectiveness, but most of them don't. This was a review from 2016, again, basically saying, you know, nothing's working. What had been tried, CBT, problem-solving therapy, behavioral activation, things like this, or even self-management training like you might do for diabetes. In the 2020 review that I did, that I showed before, we reached the same conclusion, although some studies of some of these interventions do show positive effects. But often what happens is they might only last for, you know, 2 months, but not 6 months. Or it turns out that 65% of the original sample dropped out of the treatment. So it's hard to know, it's hard to say that this really worked when most people didn't even complete it. This paper, I wanted to show this because I was really excited when I read this back in 2012. I thought, well, this is going to change everything. It's a big, great study of like problem-solving therapy by people who really know what they're doing. And then in 2016, the results of the study came out. And it basically showed that there were no effects on depression, essentially. It didn't affect depression. Now, problem-solving therapy can improve some aspects of well-being and quality of life because you're able to do more things. But the effects on depression generally have not been significant. Some studies do show it, like I said before, but often it doesn't last. And then there's someone here, Sylvia Sorensen, who actually does have some positive data on it. But in general, if you collapse all the studies together, there's not a large effect. This is a review paper from just 2025 of CBT. And this, I highlighted the conclusion of one of them. Interventions for people with vision impairment yielded a non-significant difference in depression symptoms, with no studies found examining anxiety symptoms. Right? So it's like we have to ask ourselves, what's wrong with us? Why aren't people studying treatments for anxiety in this population? And why don't we have better interventions at this point? Now, like I said, some individual studies have shown effectiveness. This one I wanted to highlight by Barry Rovner, who's done a lot of work in this area, and on depression prevention in general. And this was a pretty large study with AMD and people who had depression symptoms, but who did not meet criteria for a mood disorder. So I want to make that very clear. The treatments were everybody got low vision therapy, but half the group got behavioral activation and half basically they just talk more to their low vision rehab therapist. And what behavioral activation was, in this case, was emphasizing the link between action, mood, and a sense of mastery, promoting self-efficacy and social connection as ways to improve mood and function, and countering self-defeating behavior. So in a way, it's addressing a lot of the risk factors for depression in this population. The treatment was done by an occupational therapist in the patient's home over about 6 sessions each, over about 8 weeks. And it was focused on helping the person meet goals that they defined. So in a way, it was like acceptance and commitment therapy overlap a little bit, where you're helping the person do what they think is meaningful and getting meaning back in their life. And then they looked in the follow-up at the rate of diagnosable mood disorders, again, which nobody had initially. And they found that 12%, 12.6% had now a diagnosable mood disorder in the control group, in the behavioral activation group, but that still was about half of the rate of depressive disorder in the group that did not get behavioral activation. So that, I think, is significant. And again, focusing on behavioral activation, self-efficacy, and a sense of meaning in life, these are very important. So some recommendations that have come out of the literature are, as this is not a surprise, people with vision loss and significant mental health issues should have available to them support, counseling, or therapy with counselors specifically trained, not just generic grief counselors, to work with people who are recovering, both recovering skills, that's what I mean by external, and internally having a sense of personal recovery from this trauma to kind of regain your sense of self. So focusing on both internal and external factors. Now, it's been recommended that the counseling should come first before people even go into vision rehab or low vision therapy. I don't know if that's necessarily true. I understand it because, of course, people, if you're depressed, you're not going to want to learn Braille or even show up to treatment to use the white cane or whatever. So there's a sense to it. But I've seen a lot of people do both at the same time. But certainly for people who are having significant depression symptoms, it can help the results of the vision rehab work if they're also working on their mood. Conyers even went so far as to say that the services would be enriched by meeting the internal needs. So this is basically what I'm saying again. And I think this is less of a radical point now than it was 30 years ago, but it's still very relevant. We can't only focus on, can you do this, can you do that, can you do this? Here's how you can learn to do that. We have to focus on how the people feel about themselves and their future. People with lived experience of vision loss can be useful, in my experience, providing these services and should be included. So going back to that task force for mental health and eye care providers, again, we have to be sensitive to the fact that we're working with people who pretty suddenly maybe can't do many of the things they used to do. And that's kind of unique in terms of people who are often seen for psychiatry. Loss of independence and often the reaction that's infantilizing by caretakers. People, at least initially, often can have a flood of emotions. And again, this can interfere with both remembering information, but also adhering to interventions. And it is important to keep in mind, someone who's born blind is very likely to have, or less likely to have a problem with mood disorders because they've always been that way. Whereas if you have to now relearn a lot of things, and especially if it's happening gradually, where every time you think you've now adjusted, now it gets worse again. So we have to take into account these differences. Some of the recommendations include increasing training for eye care providers on the importance of empathic communication. So I'm reminded of our coaching program that we have here in our department, and focusing on building up social support networks and having the right kind of support. Also training eye care providers and primary care providers on the grief process. What is it? What are the stages, if you will, even though it's not linear and they're not totally separate from each other. But teaching people about the process so they can even think about where somebody is in this recovery process, and then hopefully someone in that practice can have a discussion with them that leads to a referral to mental health. And that kind of training should also be given to mental health providers. I want to say here that these days everybody wants an integrated model. So I support an integrated model. But more than that, I'm happy to say that right now, George Nasra and I and Kwasi Boeti and Karen Allison, and along with Ben Lee and David DiLoretto from ophthalmology, have been meeting and discussing the development of a provision of behavioral health services for people with eye disease or vision loss. So we're going to do this here, and we'll actually be one of the only places that is doing this. The Lighthouse in New York City has a very good mental health program, but that's, of course, a vision loss facility. It's not common to find it in a medical center, so this is something I'm very excited about. I did want to mention some resources here. I would love to think that everyone in this room is so interested in this topic that you're going to completely change your career trajectory now and go into this field, which would be great, but bad for the people you're currently working with. So let me tone that down and say, if you found this interesting, there are many resources that you can go to learn more. One is the Hadley School's website. This is a real school, though, out in the Midwest. I once took a course on that website called Blindness Basics. I learned a tremendous amount. Unfortunately, that course isn't there anymore, but they have many courses that are there that are really well designed. They're all, virtual. They produce this thing on their website, same website, Insights and Sound Bites. And these are like 4 or 5 minute personal statements or experiences that people call in and leave like a phone message. So they're all pretty short, but you really get a sense of what people are going through or what they went through and where they are now. So again, you don't have to sit there for 3 hours. It's not like a MyPath training on fire safety. It's much more useful, I think. So please go to Insights and Sound Bites. You'll be glad you did. There's the Living Blind podcast, Blind Guy Travels podcast. These are all, you learn a lot about what people are going through and how they cope. This RNIB from the UK is really interesting. I've heard some interesting podcasts there, not just the typical things like what it was like to learn to use a cane, but, like what's it like to go on a date and try to have sex after you lose your vision? So very real life, real people type of situations. And again, if you're going to be doing group therapy or individual therapy with people going through this, it helps to know what people say. Not just your own client, but other people. And the point is there are many others. Prevent Blindness is a great organization with many useful things. There's a great large literature of books by either professionals or people with lived experience of blindness. I have a whole bunch in my office. If anyone wants a recommendation, please stop by. And then this book that I recommend, When You Can't Believe Your Eyes by Hannah Fairburn. There's a website associated with it, also has some good videos on it, and there's really good advice in that book for people who are losing vision. Additional, I'm just going to skip through this really quick, but to say there are many, many other resources out there. And I want to end by saying, before I came to the U of R, I came back here I was running a program at Rutgers University through the medical school there that was called the Eye to Eye program. I hated the name. I didn't choose it. The people who worked in the program chose it. The idea was because there was no mental health expertise in the state, we trained people who were blind, sometimes from birth, sometimes losing vision over time from disease or injury. So they were blind. We trained them to be peer mental health counselors, and then they ran essentially a phone helpline which started very small in New Jersey, but now it's gone nationwide. Well, I mean, it's based in New Jersey, but they get calls from all over the country. So this is the phone number, and if anyone's working with someone who's losing their vision and has concerns and wants to talk to other people who've gone through this, I recommend to call. There's a picture of me from pre-pandemic with no COVID beard. But we started this program. It's got a fair amount of attention. In fact, I was asked to write this article for this ophthalmology nurses journal, which I'd never heard of prior to being asked. It was a lot of fun, and I got to describe some of the really ridiculous experiences, which I hope someone asks me about in a minute, that we had to go through to set up this program, not dealing with the peers, but dealing with the university and what it's like to try to set up a program for blind people at a university. It was amazing. It was like some crazy surrealistic movie. So to summarize, there are effects on mental health of vision loss. Many people, but not all, about 30% experience problems and a desire for assistance with mental health needs. These services are generally not available. And the services that are available from the rehab point of view, maybe will reduce depression about 10%, but even the ones that are available from the mental health side, at least in the meta-analysis way of thinking, don't have very strong effects, including CBT, which some people younger than me think, well, CBT, that cures everything. All you need to know is CBT and everything gets better. But that's not always true. And in fact, in my view, many people with the amount of issues that they're dealing with need more than 6 weeks of seeing a counselor to deal with some concrete tasks. They need to work on who they are and how are they going to be a person in the world that's as worthwhile as they were before, now that they're losing vision and dealing with it. Peer support services, I think, are great, but we don't really know how well they work for this population, and we need more clinicians who are experienced in this. So feel free to talk to George or me about interest in the work that we're developing. And of course, it's going to be integrated. Okay, so that's it. Thank you for your attention.
Thank you so much, Steve. I'm going to be moderating the Q&A. I do just want to say on behalf of the other associate chairs, my path is not terrible, and I would encourage you all to do your My Path training. I'm sure Steve feels that way too.
Maybe I can get one of the other associate chairs to complete my courses for me.
Okay.
If people like it that much.
We do have a few questions coming in on Zoom as I elegantly sidestep the My Path question. Are there questions in the audience as well before? Ben has one. Okay. Let me come over to Doc. Oh, sweet. So it's a really long walk.
More of a comment than a question. Department of Psychiatry and Department of Ophthalmology has been discussing this development of behavioral health support for the low vision and people with blindness. And we are very committed to do this. And we are in unique situation of having both chairs committed to do this. So we are very much looking forward to see more trainees and students interested in this. So please do contact us. I mean, we are so interested. I asked David DiLetto, who is the chair of the ophthalmology, asking him, do you really want to take on this yourself? And, don't you want to assign this to somebody, another faculty member? And he said, absolutely not. This is his passion project. And I also feel this, along with our deaf wellness program, is something that our department should and really take on. And we are very interested in this. So I would very much like to see trainees or junior faculties, anyone interested in this, to contact Steve and George and others to really develop some people around this program that we are about to develop.
Terrific, thank you. I'll put in a plug as well for family treatment. Oh, you could do it. I did it. Family treatment. So Dr. Silverstein talked a lot about caregivers sort of being involved in all kinds of ways, but encouraging people who have a family orientation or training in family interventions to consider as well. This was a great talk. Nobody said this. I'm just saying it from myself. But here's, that came out wrong. Okay.
Thanks for pointing out that nobody said it, but okay, what's the rest of the comment?
Somebody said you made a good case. Let me start with that. You made a good case that blindness can lead to various forms of psychopathology like depression. Could you also say something on the relationship between blindness and psychosis, or the question mark about psychosis?
Yeah, that's a whole nother talk, but, so I'm out of my slides now, but basically there's a fascinating literature that I've reviewed, and there are a number of reviews out there from the last few years, which suggests that if you're born blind, you won't develop schizophrenia, right? So it's protective. And why that is has to do with, nobody knows, but there's the changes that happen in the brain with congenital blindness are kind of like the opposite of what happens in schizophrenia. So in terms of like superior auditory processing and memory, and even some of the thickness or thinness of brain structures are the opposite in like the visual cortex and blindness versus in schizophrenia. So, and there are studies that have been done, even of 1 million people, that show that, especially if the cause of the blindness is in your brain, that no one's ever identified anyone who was born with cortical blindness who develops schizophrenia. And the rate of peripheral blindness, or when the problem's in your eye, is something like 0.2%. It's about 1/10 of the normal rate of schizophrenia. Of course, if you become blind later, there's no protective effect. But yeah, that's a whole separate topic, but that's a fascinating literature. But today I just wanted to mainly focus on the things we can treat from the mental health point of view.
Thank you. Here's a comment and not a question, which is, I think, a nice one to wrap up on. The Hope Labs social connection coaching sounds like a really natural fit for adults experiencing vision loss. While our program was initially designed for older adults, explicitly targets functional impairment as a driver of social connection, and so it wouldn't require many modifications to help those with vision loss. And it was designed to be delivered by non-mental health professionals, can be done on the phone. So something to consider for you and your team.
Can I respond to that?
Yes.
My response is, Kim Van Orden, you should really come to Grand Rounds in person. But no, I agree, and I think I hope Kim and I can talk about this, because a lot of her really good work with social connection and depression and older people, it's really relevant to this.
I never said that person's name, and I'm not going to say it now. But thank you so much to all of you for coming. Thank you for a very interesting talk, and have a great afternoon.